Getting stuck between two answers and constantly picking wrong, you're not crazy, you're being sabotaged by how you read. You might know something's not quite right. Your friend studies less but scores 80s on UWorld, you narrow it down to two choices and somehow always pick the wrong one. Here's the truth, 50% of missed questions have nothing to do with knowledge. In this recorded tutoring session, watch a student discover why her brain kept choosing wrong, despite knowing more than classmates scoring 20 points higher. One fix and her NBMEs jumped 12 points in 7 days. Plus, she only used it for half of her test. Imagine if she'd used it for everything. You could be 20 to 30 points higher without studying one more fact. Watch the exact moment that she realized how. So how was the process of going over your standalone questions again? And we're kind of revising them.
Some of them were clearly off, and I saw how much they were off by, with the exercise that you gave me. It kind of drove home the point that, like, okay, really having a strong ability to generate a high quality standalone question, it's really valuable. So I will be doing this religiously moving forward.
So it's like, it sounds like what you experienced was when I can simplify the question and kind of peel away, abstract away the details, and I understand the concept that they're testing, it's actually kind of obvious what the answer is or is not. Awesome. So let's jump in. All right, so this is great. Okay, perfect. Oh, and I love the fact that you included your initial standalone question as the new one. Okay, so this one I think is good. So I like the fact that it's a lot shorter. I'm not sure. I actually think that there was an element of your initial standalone question that was you probably still need to include. Because obviously for moderate colon cancer, you would be thinking about the actual treatment of it, right? You would be thinking about if I'm thinking colon cancer, mild, moderate, severe, I would be thinking of chemotherapy. I would be thinking of.
Yeah.
So I do think that you do need to have the workup.
So it could be edited to what is the initial workup of possible colon cancer? Or no, it's actually it's on colonoscopy. So what is the initial workup of moderate colon cancer? Would that...
to be honest, I actually think, how important is it that it's colon cancer?
How important is it? I think it's important in this case, especially given the options being...
If you have lung cancer, so sure, but if it's liver cancer, if it's pancreatic cancer, if it's...
No, it's actually not important.
In other words, I think this is a principle, is my guess, right? So one thing that I think people struggle with, that I struggled with when I took these tests, is I would think oh man, this is a very specific scenario. How would I possibly know, right? Again, it's kind of the extreme version of this is in a 62-year-old man who has biopsy-proven adenocarcinoma of the sigmoid colon, what's the next step? That seems impossible, right? But even saying, what's the initial workup for colon cancer might seem kind of tough. Honestly, that might be, it's answerable, but you have to have still some reasonably specific knowledge. But what if I just said, what's the workup for pretty much any cancer?
Yeah, you have to do CT to...
You got to stage it, right? And so I think that the key thing here is not that it's colon cancer. It's what do you do whenever you have a biopsy-proven cancer? You've got to stage it.
I see. Okay.
Right. And so the standalone question actually could be something you could either say, I don't know, what do you think? So based on that, how could you sort of simplify it?
Initial workup for a newly discovered cancer.
Yeah, exactly. Yeah. How do you work up a newly discovered cancer? How do you work up a newly discovered intra-abdominal cancer?
Sure.
Right. Does that make sense?
I could have made that even more conceptually, really just zone. Yeah. Got it. Zoomed out even a little bit more.
Right. It's kind of there's those questions about, sometimes shows up on step 1, sometimes on step 2, where they'll be what is the best next, what would they say? Which of the following would be most important for prognosis? And for the vast majority of cancers, it's stage. right? And so you can ask it as like, what's the next most important, like what's the most important part of prognosis for pancreatic cancer? What's the most important part of prognosis for hepatocellular carcinoma? What's the most, right? But like in reality for 95% of cancers, like it is going to be staged. If it's, you know, if it's like widely metastatic, that's obviously really bad.
Right. Correct.
And so the key is still, you want to figure out what the principle is. You want to abstract away the details. And then you know, in your cards, right? You want to, in your Anki cards, you want to make a card that sort of represents that principle, not like, because what most people will do when they get a question wrong on this is they're going to say, what's the workup for colon cancer?
Yeah, that's me.
If instead you want to ask yourself, oh, okay, like, is there a principle here? And you can say, like, what is the workup for, you know, so like, there's two ways you can make this card. You could say, you know, colon cancer. What is the workup? And the initial workup. The alternative would be to say colon cancer using a general principle. What is the initial workup? And so in this case, this makes it seem like it's just a fact that I'm going to have to remember, and I'm going to have to know for every single possible cancer what the workup is going to be. And I'm going to miss that maybe 80, 90, 95% of the time is just going to be like some version of the same thing.
Yeah.
Or I can do this like once, twice, 3 times and say, okay, well, using a general principle, what is the workup? And then use this card as a way to reinforce a general principle that then, because I've been reinforcing it, now when I actually see it on a question, now I'm able to correctly identify the concept behind the standalone question. Does that make sense?
Yes.
Yeah, that's the key. Again, we're not trying, like, we could, right? The sort of like pre-made Anki card approach is to try to take everything as if it's a fact, to try to just memorize it and be like, oh yeah, you know, like for a 4.5 centimeter adenocarcinoma, like what's the next step? And it's like, you can do that, like that's okay, that's fine, right? It's just a lot more work. You're creating a lot of extra sort of pain and I think unnecessary suffering for yourself. Whereas if you're like, okay, like there's a handful of principles here, like let's try to figure out what those principles are. Take some extra time to figure out what those principles are. And then I will make a card that kind of reinforces everything as a principle. All right, so let's look at this. What is the cause of stress incontinence in a patient with pelvic floor?
As this, I just try to make it tighter, like try to shave off a couple of words. But
honestly, I think you could probably simplify this by saying, like, what is the cause of stress incontinence?
I
think, right? Yeah, because like, if we look at this is urge incontinence. This is stress incontinence. I don't know why this is here. This is urge incontinence. Wait, constipation, that seems weird. Estrogen deficiency, right? But like, that's essentially it. Right, they're giving you different kinds of incontinence, urinary incontinence, and then some other stuff too. Yeah. It sounds, so there's kind of 2 parts. If we break this down, it sounds like there's kind of 2 parts to this. The first is, did you know that this was stress incontinence in the first place?
Yes.
Oh, right. And then B, did you know the cause of stress incontinence?
Yes, embarrassingly, yes.
Okay, so walk me through. Well, so again, this is very common. The reason why people miss questions isn't because they didn't know it. Oftentimes it's because they just didn't apply it in the right way. So walk me through, what was the thought process for, if you knew A, that it was stress incontinence, and B, you knew the cause of stress incontinence, how did you still miss it? What was your reasoning for choosing
Well,
C?
So for this question, I really honed in on the fact that there was, I thought I read somewhere in this question that the patient had like an anterior vaginal wall like protrusion. And it, somehow in my mind, I thought like, oh, maybe she has like impacted stool, and maybe that's pressing on her urinary tract and causing like a backup of urine. That's literally what happened in my head. And I Also, I'm not seeing it now, but in the moment, I recalled reading something about her also having, like her last bowel movement was like 3 days ago or something.
Like, so it's very, very likely that a question could have something like that in the actual test.
Right.
Right. The classic example is, I don't know how many questions I've seen on UWorld or Step 2 or shelf exams where the patient is having an MI, but they've got like some other cause for chest pain. Like, for example, they will often have GERD. They will often give that patient GERD. And I never understood why until I realized, oh, they're trying to give you an alternative explanation for why they have chest pain. So same thing with this, right? They're giving you an alternative explanation for why something, like they're giving you constipation, right? It may be true even that she has constipation, but it's not that, like, you have to read the question, right? It's like, what is, so that's why the standard question is so important. What is the cause of stress incontinence?
Exactly. Yeah.
Right? Constipation might be true, right? It's kind of like they might give her hypertension. Hypertension might be among the answer choices, right? It might be true. It just might be unrelated to the actual question that they're asking. That makes sense?
Yes.
So again, why it's so important to ask yourself and remember, like, what exactly are they asking me? And also, in fairness, another good plug for why it's important to do rule in before you rule out. Right? So like, okay, urethral hypermobility. That is the cause of, well, wait a minute. That is the cause of stress incontinence. Wait, what? Constipation? I mean, that's true, but it's not the cause of stress. Oh, I see what they did. Oh,
Hi. Yeah.
Right.
I think that's going to be the next frontier for me, Dr. P, is doing a rule in, rule out every time, and especially so when I know I'm panicky. Like that's going to be the next, I think, level up for kids.
Well, so that's the other thing I wanted to talk about. So I want you to actually reframe the way that you view that emotion, that sensation.
Okay. Please tell me.
There was an interesting research around, someone made the observation that excitement and worry or anxiety feel the same inside of our bodies. And what determines whether we view it as excitement or worry is our sort of metacognitive process.
Oh.
In other words, our interpretation of those same signs, right? For example, like I kind of trained myself as I was doing these questions to see a hard question and say, oh, heck yeah. Like, oh, this is gonna be a good one. All right, like game on. As opposed to like, oh my God, another question that I don't know. Right, like,
yeah, that's me.
Yeah, exactly, right? And so instead, I want you to look at it as like a challenge among equals. And I think as someone who has struggled with insecurities and feelings of inadequacy for a large portion of my life, I also know that when you start with the assumption that you're not good enough, it's really easy to find evidence to support that assumption.
Yeah, really.
Right? And so if I'm thinking, oh God, oh, this is going to go poorly. Oh God, I'm not good enough. Oh God, I'm not a good test taker. I will find, especially on a test like Step 2, I will find plenty of evidence to support that assertion. So when that happens, because it will happen. So A, I want you to expect that it's going to happen. B, when it happens, I want you to tell yourself, oh, heck yeah. Like, ooh, this is a good one. Right? I used to kind of imagine myself in like a boxing ring. You're like, okay, oh man, you got me good on that one, but like, I'm going to get you next time. The other thing too is like, remember that, like, I think that it seems kind of like you take it personally if you can't know exactly what's going on in the scenario.
Oh yeah, yeah.
Like in this case, you were like, oh man, I'm just thinking like the narrative of someone in a situation like that might be, God, what's wrong with me? How can I not know what this is? God, I just studied this. Or, oh my God, like I like know GI. I just, whatever. Instead, you want to be objective and say like, honestly, I don't think I have enough information to know exactly what the diagnosis is. Maybe someone does, but like it's not clear to me at least what is going on. Like, I know it's like generally a transit problem, but I don't know that this is necessary. Like, I can't tell where. I don't think so.
Yeah.
Right. And in the cool light of day, you can see that actually I don't think they have given us enough information to know. Let's look at this next one. Oh, I see. So there's kind of two parts to this. One is that I'm going to guess that you probably knew that you don't want, well, I don't know. Like one part of getting this question correct is that you have to understand that obviously you're not supposed to have maternal blood mixing with fetal blood if they've got a bloodborne thing like HIV. Another thing is that you have to know the other one, and this is kind of a knowledge thing. You have to know that fetal scalp electrodes are like sharp and scratchy and can cause bleeding.
So I went into this question without knowing that. I thought it was like EKG electrode, like, oh, maybe you just stick it on. Yeah, so that I didn't have that knowledge, but
that's okay. To be honest, this is maybe one of, if not the first question where I'm like, oh man, you did not know that, and that was why you got it wrong. That's okay. Like, honestly, if this is, so all the stuff that we've been saying up until this point is just to reinforce the fact that most of this is emotional. Most of this is, in your case, most of this is emotional. Most of this is making sure that you can have the right approach consistently every single time. And you know what that approach is, you just got to do it. And a lot of doing it is just, it's just, again, there's no silver bullet. There's only golden BBs.
There's no silver bullet, just golden BBs.
Right. A silver bullet is something where it's one thing that changes everything. There's no one thing for these tests that I've ever found that changes everything.
But what does the
golden BB, like a BB gun?
Yeah.
So meaning like there's lots of little things that you can do. Each one of these things can make a moderate difference. But when you put all of them together, you can see dramatic changes in people's scores. You said, oh, I'm pretending that I'm interviewing the patient there in front of me and I'm picturing everything going on. That's a golden BB. Another golden BB is, your mindset when you go in, like talking to yourself positively. Another is the reframing of the sensations. Like, oh, it's not panic. This is actually excitement. Right? Another golden BB is doing rule in and rule out every time so that you don't kind of give in to the lawyer impulse and you're more the judge. Another golden BB, right? There's no silver bullet. There's not, one of these things isn't going to be the thing that changes everything. It's doing all of these things, learning how to be consistent with all of them, putting them all together.
Fact.
And again, this is probably the first question that I've seen where like, it's probably not. And that was just something that like, I don't think I knew that until I was well beyond step 2. All right, let's look at the next one. What's the management of postpartum endometritis? Again, anytime you do this, you should try to, for management questions, what are the two things you need to know?
The severity and the diagnosis.
Yeah, so what did you include here?
I included the diagnosis.
So what would have been ideal?
Severity. Well, I don't have much to go off of, but my impression would be vignette is that it's not like it's mild.
Yeah, probably like mild. Yeah, it's like uterine fundus is mildly tender in palpation, feels slightly enlarged. Her vitals are
she's
pretty normal. Might be a little tacky. She's got some fever.
Right, yeah, but not like frank septic shock or like severe tenderness on palpation of years. So
there is some sort of specifics to this, but I kind of put this in the same category as the cancer workup question before. In general, for many infections, what do you do?
For many infections, what do we do?
Like if someone comes in with community-acquired pneumonia, like what do you do? Or if someone comes in with like a cystitis, like a lower UTI, like what do you do?
Treat it with antibiotics.
Yeah, you empirically treat.
Correct, before culture comes back, yeah. Okay.
There are situations in which you do want to culture it.
Oh, right.
Right. But like for the most part, for like a pretty standard infection that like you're not too worried about like, speciating it and like whatnot, you treat empirically. And so it's easier to remember the exceptions and then everything else becomes the rule, right? But I would still put this in the category of like, yeah, like this kind of follows my pattern of what I expect.
I see.
For a non sort of complicated infection, not like weirdo infection, or not one where it's like they're going to be on antibiotics for a long time and you have to really make sure that you get the species right because they're going to be on antibiotics for so long. For the most part, you treat these things like if somebody comes in with cystitis, you're not culturing their bladder. Of course, you give them antibiotics. You give them antibiotics.
I could have even taken this standalone question a step further, like we did with the other one, and been like, what is the management of an uncomplicated mild infection?
Yes, exactly. That's exactly. Does that make sense?
Yeah, no, it does. Then, because that was the source of my mental pain with this question. Within my mind, I was really fixating on like, but what if this is that one case where you have the culture before you start something? And I was really fixating on that. But if I had zoomed out and taken it in more conceptually and, like really acknowledge the fact that this is an uncomplicated case, it's mild, then I would be like, oh yeah, duh, like don't worry about it. Like you just get antibiotics going to start. Yeah.
Oh my gosh. I think the thing is, my guess is that like, cultures are notoriously challenging because like, is it normal flora? Is it actually the pathogen? Like, there's all that other stuff too, right? A novice at test taking is going to try to improve their knowledge. An expert at test taking is going to try to take their knowledge and make it more broadly applicable. Make sense? All right, let's look at the next one. A tall adolescent boy learning difficulties with puberty and gynecomastia. Oh, interesting.
Yeah, so this one I wasn't sure.
Yeah, fine, well done.
I kind of stuck pretty closely to what I had before. I kind of reordered it. But
how did you choose? I don't. Your standalone question in either case, I think, is fine. What was the issue? Was it that he was a normal height?
I didn't do the standalone question. That was the issue. And I really fixated on the fact that the patient has gynecomastia. And I was like, wait, but that could be normal. So then I picked that and moved on. But I didn't synthesize that there's gynecomastia, but there's also this tall height thing. And there's also this delayed puberty thing on top of that. I didn't piece them together. I just kind of was like, oh wait, but gynecomastia could be normal. So then I picked that and moved on.
Well, it sounds like it was a problem of interpretation. So it was like, as you're going through, you probably weren't doing context every time and saying, what does this mean relative to the others? Because you're right, gynecomastia by itself may not mean anything.
Right.
Right, but gynecomastia and long limbs and small testes and, scant pubic hair. And, it's like basically signs of sort of sexual immaturity while still being pretty tall.
Yeah.
And, like, it's kind of like the delayed puberty thing. Okay. Now we're thinking, yeah, maybe there's something here.
Correct.
It's probably a good PC card. And then you might want to make cards, like concept cards on like these specific things. Like if I saw long limbs with reduced upper to lower segment ratio, I'd be like, what does that mean? Right? That's the kind of thing that can, we're going to reframe the panic, right? So it's not panic, it's excitement. Like it's gonna make you excited, right? Yeah. And you see something like that, you're gonna get excited. Yeah. And so to sort of like level out that excitement, you can make some concept cards or something like that, so that you already know what those things mean in context.
Yep. Got it.
Cool. Makes sense. All right, let's look at the last one. What is the initial management of DKA? Oh,
yeah. So this I thought the standalone question was pretty good. I guess I can add the severity.
Good. Yes, exactly.
Today. So let's see. The severity in this case, moderate.
No, I would say moderate to severe.
Moderate to severe. Fine.
All right, let's look at this. Let's type.
Easy.
He's in the E.
I take it back. What are her vitals? hemodynamically not stable.
Huh?
She's not, the patient's not stable. They're tacky.
Yeah. I mean, so anytime, so what would we call those vitals?
What would we call these vitals?
Yeah, that's kind of a vague question, but yeah, I think.
Unstable?
Yeah, but she's in shock.
Oh,
Technically, this is shock, right? Anytime. So technically, the shock index is if your heart rate is ever 90% or above your systolic blood pressure, that's technically shock. So if you've got a heart rate of 90 and your systolic blood pressure, if your blood pressure is 100/60, your systolics are 100. So technically, that is shock. So if your heart rate is 90, 91, 92, 93, 100, 110, that's shock. On like USMLEs, oftentimes they're going to make it more obvious than that. And so you're not going to have to calculate like, oh, is this 90%? Is this systolic blood pressure? It's like, if your heart rate is ever above your systolic blood pressure, that's shock. Right? So I know it's weird because I think everyone else, when they originally saw this, they were like, oh, well, blood pressure is like, okay, it's fine. Right? You see that and you're like, oh, that's an okay blood pressure. You have to look at the heart rate before you look at the blood pressure. So she's presenting to the ED. She is in shock. She's like floridly acidemic. She's lethargic, right? So she's got signs of end organ dysfunction.
CVS, yeah.
Her parents brought her. So again, this is a sign of even worse severity because she didn't bring herself. It was someone else that brought her. I mean, yeah, okay. So they like last night. So she forgot her insulin last night due to a missed dose. So like, girl doesn't take her insulin, and so like, my guess is you knew the diagnosis.
Yeah.
And so yeah, but so part of this is recognizing the severity. And so you're like, okay, so someone comes in hypovolemic shock in DKA, or someone comes in with severe or moderate to severe DKA. What's the next step?
You have to get fluids. Yeah, and oh my God.
What did you choose? A?
I chose insulin.
Which one? A or E?
I chose, which was that?
Rapid acting?
I think I chose rapid acting, yes. So I'm realizing this now, Darky. I did not register the severity of his case. I did not. And I did not acknowledge that this patient was in shock. And if I had done that, of course, fluids, then you got to address that for, yeah. So this is a good exercise. My goodness. Okay.
So this would be a really good PC card. Really good PC card, right? Yeah, it's doing the right things every time, not some of the time. So it's like going back to the basics: context for knowledge of severity, standalone question, rule in and rule out, right? And then having that mental fortitude of like, things get tough, I get excited, right? You want to run towards the flames. You want to run towards the smoke. And because you realize once you do that it's actually not that bad. Right? Like, actually, it's not that bad. And like, yeah, you're going to get knocked down some of the times. Just like Tyson, like, everyone's got a plan until they get punched in the face. Right? Like, you're going to get punched in the face. Like, just expect it. That's okay. Right? That's the fun of this. What are your major takeaways from this process and our discussion today and previously?
Well, I mean, one of the takeaways is the same, is when every question, sticking to the same protocol, no matter what is kind of going on, whatever feeling I'm feeling at the time, and continuing to expect the questions to be hard, expecting questions to be ambiguous and not internalizing that. I think that came through more today than yesterday. So we'll continue to work on that, strengthening that muscle. And with the standalone question, I need to acknowledge the severity. Definitely missed that on a couple of these questions. And that was actually, could have been, if that was there a little bit more robustly, the likelihood of me getting it right would have been significant.
Love it. Yeah. And remember, there's no silver bullet. There's only golden BBs. Like, all of these things, none of these things by themselves is going to make the entire difference. But when you're just kind of, you're plugging those holes. Any last thoughts, questions, concerns?
No, just that I'm grateful to be working with you and I'm happy to be a part of this community. Ready to level up. It's time to level up.
You just learned the framework to review any NBME question, but how do you use all this to actually get a 260 plus? In the next video, I'll show you the exact daily plan. You'll see how many questions to do, when to use Anki, and the schedule that got multiple students to 260 plus. This is the complete system that puts it all together. Click here to watch how to virtually guarantee 260 plus on step 2 and see the full roadmap that makes a top score almost automatic.